When we say a child's dialysis is adequate, what do we actually mean? Is it just a number on a lab report, or does it reflect whether that child can grow, go to school, and actually live their life? In today's video, we're breaking down a key educational review by Dr. Linda Ding, Dr. James Johnston, and Dr. Mori and Pinsk, titled Monitoring Dialysis Adequacy, History and Current Practice, published in Pediatric Nephrology in 2021. We'll look at how our understanding of adequate dialysis in children has evolved from focusing on urea clearance to a much more holistic, patient-centered view. By the end of this video, you'll be able to describe the historical focus on urea kinetic modeling for dialysis adequacy in pediatrics following adult practice. Explain why urea is only part of the picture when it comes to outcomes in children on dialysis. List key non-urea parameters that should inform dialysis adequacy in children. Apply a livable dialysis framework that centers the child's quality of life, not just lab targets. This video is designed for pediatric nephrology trainees, dialysis nurses, dietitians, and anyone interested in evidence-based care for children on dialysis. The review by Ding, Johnston, and Pinsk emphasizes that pediatric dialysis adequacy historically followed the adult world. Adequacy was judged mainly by urea kinetic modeling, using measures like K/V and urea reduction ratio URR, both in hemodialysis and peritoneal dialysis. These models were originally developed in adults and became the backbone of early adequacy targets, including trial data showing associations between higher urea clearance and better survival in adults. Pediatric practice largely adopted these tools to estimate the dose of dialysis needed. In children, this meant setting minimum Cut/V targets for PD and HD, adjusting prescriptions, dialysate volume, frequency, and duration to hit those urea-based numbers, using urea as the primary surrogate marker for good dialysis. Ding and colleagues point out that while this was a useful starting point, it quickly became clear that urea alone cannot capture the complexity of a growing child on dialysis. According to Ding, Johnston, and Pinsk, urea clearance is only one piece of the adequacy puzzle. Urea is a small, easily dialyzable solute, convenient to measure, but not necessarily the driver of all clinically meaningful outcomes. The review highlights that multiple clinical parameters and interventions are now known to have impact on mortality and morbidity comparable to or greater than urea clearance, including volume status and blood pressure control. Chronic fluid overload is strongly linked with left ventricular hypertrophy and cardiovascular risk. Nutritional status and growth. Poor growth, low BMI for age, and inadequate protein energy intake predict worse outcomes in children with CKD and on dialysis. Anemia management. Suboptimal hemoglobin is associated with reduced exercise capacity, school performance, and quality of life. Mineral bone disorder control. Abnormalities in calcium, phosphate, and PTH impact bone health, growth, and vascular calcification. The key message from the authors: a good K/V with poor blood pressure, poor growth, or repeated hospitalizations is not adequate dialysis in any meaningful pediatric sense. The review by Ding, Johnston, and Pinsk argues that our concept of dialysis adequacy is evolving to deliberately include non-urea parameters and patient-centered outcomes. A more modern approach to adequacy in children includes at least 4 domains: biochemical and clearance targets. Still important urea-based measures like K/V are still used to ensure a minimum dose of dialysis. Other solutes and markers, such as potassium, bicarbonate, and phosphate, help capture broader metabolic control. Residual kidney function is recognized as highly valuable, often conferring better fluid and toxin control and better outcomes. Volume and hemodynamic status, dry weight assessment, interdialytic weight gain, and blood pressure trends are critical. Dialysis prescriptions are tailored not just to clear urea, but to achieve euvolemia and avoid intradialytic instability. Growth, nutrition, and development regular monitoring of height velocity, weight for age, BMI, and mid-upper arm circumference is essential in pediatrics. Collaboration with dietitians to optimize protein and energy intake while respecting fluid and electrolyte restrictions is now a standard part of adequacy planning. Quality of life and functional outcomes, Dean and colleagues emphasize assessing how so-called adequate therapy actually affects the child's daily life. School attendance, participation in activities, sleep, and emotional well-being. In practice, this means considering treatment schedules, symptom burden like pruritus, headaches, fatigue, and the demands on families. The review frames adequacy as a multidimensional construct, with urea as one factor among many, and clearly calls for routine, structured assessment of these additional domains in pediatric dialysis programs. One of the most important conceptual shifts highlighted by Dean Johnston and Pinsk is moving toward therapy that is not just adequate but livable. This means asking questions like, can this child attend school regularly? Is the treatment schedule compatible with family life? Are we minimizing hospitalizations and emergency visits? Does the child report acceptable symptom burden and emotional well-being? The authors argue that as we enter a new era of pediatric dialysis, we must actively consider the impact of therapies on the child's quality of life, not as an afterthought, but as a core goal of adequacy. Translating this review into everyday practice, here are key EBP evidence-based practice points informed by Dean, Johnston, and Pinsk's 2021 article. Use urea kinetic modeling as a baseline, not the full definition of adequacy. K/V and similar measures remain essential to ensure minimum clearance. Systematically monitor non-urea domains, volume status, blood pressure, growth and nutrition, anemia, bone mineral control, hospitalization rates, and quality of life. Prioritize residual kidney function when possible by avoiding unnecessary nephrotoxins and tailoring ultrafiltration strategies. Embed quality of life into adequacy discussions. Ask children and caregivers directly how dialysis is affecting their lives, and adjust where feasible. Document and review these parameters regularly in multidisciplinary rounds, treating adequacy as a dynamic, evolving target rather than a fixed number. The central message from Dean, Johnston, and Pinsk is that children deserve more than adequate clearance. They deserve a therapy that lets them live as fully as possible, because quality of life matters. If you're involved in caring for children on dialysis, consider how your program defines adequacy. Are you focused mainly on urea, or are you looking at the whole child? The ideas in this video come from the Educational Review Monitoring Dialysis Adequacy, History and Current Practice by Dr. Linda Dean, Dr. James Johnston, and Dr. Maury N. Pinsk, published in Pediatric Nephrology 2021. If this helped, please like, share, and subscribe. Thank you.